Hello and welcome to Emergency Medicine Quest. In this lecture, we are going to talk about venomous injuries, which account for serious morbidity and mortality across the world. It is important to understand what organisms are poisonous and what organisms are venomous. Poisonous are those that have toxins in their tissues, like shellfish, that causes death after ingestion. Venomous are those that have specific glands that produce venom connected to an apparatus for delivering venom. So, snakes affect the extremities mostly, with men more likely to get bitten than women. There are five classes of snakes that we need to know of: Colubridae, Elapidae, Viperidae, Crotalidae, and finally Atractaspididae. So Colubridae actually represents 70% of all the species of the snake. They are rarely dangerous to humans because although they have got venoms, the fangs are too small to actually envenomate humans. Elapidae include cobras, mambas, and coral snakes. Viperidae represents true vipers. Crotalidae represents pit vipers, and we are going to talk about pit vipers and coral snakes in just a moment. And finally, Atractaspididae. These also rarely envenomate humans. If we talk about coral snakes represent major problematic group of venomous snakes. So now the question arises, how do we identify them? So if we notice, their nose is black and red is always adjacent to yellow. So there's actually a rhyme that is mentioned in Rosen's: red next to yellow kills a fellow, red next to black and venom black. So just remember that because it helps differentiate coral snakes from king snakes. There's a caveat to this, and that is it is only applicable in the US because in Brazil, coral snakes appear differently. Pit vipers represent the other major category of venomous group of snakes in the US and are actually more common than coral snakes. So they have three main groups. So they have got rattlesnakes, they have got water moccasins, or what you also call copperheads, and then they have got pygmy rattlesnakes. Now, why are pit vipers called so is because they have a pit midway between their eye and the nostril, so that's a pit. And this is the most sensitive way of identifying a pit viper. It's 100% consistent across all the subgroups of the species. It's actually a heat sensitive organ that helps in locating its prey. But there are other not so reliable methods to identify pit vipers, like triangular head, its elliptical eye or pupil, the presence of fangs, and the way its tail is structured. So there are two main factors that affect the pathophysiology of venomous injuries. One is the toxic property of the venom itself, and the other is the response of the toxin by the victim. Now, the toxic component of a venom can be classified to have proteinous compounds and non-proteinous compounds, but what we see is that 90% is the proteinous compound. Some factors that influence the effect of snake bite are age of the person, toxicity of the venom, comorbidities of the patient, the anatomic location of the site. So if we talk in particularly about pit vipers, we see that immediate burning pain is the most common manifestation. There can be some associated swelling and edema. Most times the fangs do not penetrate into fascial compartments, but there can be some muscle destruction due to direct toxicity. If there's a distal bite to a toe or a finger, then the mortality is actually pretty low. But if it is intravenous, then it can be high. Death from pit vipers is due to disruption in the coagulation mechanism and increased capillary permeability, which can cause pulmonary edema, shock, and eventually death. If we talk about coral bites, we see that ptosis is the most common presentation, but it can also present with vertigo, paresthesia, fasciculation, increased salivation, and proximal muscle weakness. Regarding pit vipers, so there are 5 grades of pit viper bites that is described in Rosen's from grade 0 all the way to grade 4. So 0 is minimal, that means there is no evidence of envenomation, but a snake bite is suspected. There is minimal pain, less than 1 inch of edema, no systemic signs, no lab abnormalities. Grade 1 is also minimal, but there is minimal envenomation and a snake bite is suspected. Pain is moderate. There is 1 to 5 inch of edema and erythema, but again, no systemic signs and symptoms, no lab abnormalities. Grade 2 is moderate. There is moderate envenomation. There is more pain. They have edema spreading towards their trunk. There might be some nausea, vomiting, mild fever, but no lab changes. This is what differentiates it from 2 to 3. In grade 3, there is severe envenomation, so edema is spreading towards the extremity, the trunk. Labs wise, we see increased WBC count, creatinine, phosphokinase, uh, prothrombin time, PTT, D dimers, all that. And grade 4 is the most severe, so there will be sudden pain, less than 15 minutes of bite, rapidly progresses, swelling and ecchymosis, blood formation, necrosis. There'll be so many systemic manifestations like nausea, vomiting, vertigo, metallic taste, numbness. We will see muscle fasciculations, painful muscular cramps, sweating, convulsion. In severe cases, we'll see coma. And if the bite has hit the intravenous space, then there might even be a cardiopulmonary arrest. Management wise, it is very important to understand that snake bites are an emergency. So, in the initial 6 to 8 hour period after the bite is very crucial. So, we can divide our management based on out of hospital care and in hospital care. So, there are certain principles when we're talking about out of hospital care. So, first of all, something that's very intuitive is to remove the snake, and better if we can kill it. So, remove the snake from the patient and, if possible, bring it along. Then, the patient should be rapidly transported to a hospital. Any constricting jewelry or any constricting cloth must be removed from the extremity because we do not want a tourniquet effect. Now, there are factors that can actually increase the spread of the venom, like patient's excitement and physical activity, movement of the bitten area, alcohol consumption, and the depth of the bite. Obviously, the depth of the bite cannot be controlled because it's already been done, but what we can do is immobilize and compress the area. We can give some ice to the patient. Now, this is not going to affect particularly the spread of the venom, but it might relieve some pain. And the presence and evolution of any wound and limb edema is crucial. In hospital care for ED involves, remember our basics, ABCs, airway, breathing, circulation. Don't forget this. We have to make sure that before we initiate anything, the patient has to be stable. So they may be hypotensive because of third spacing or hemorrhage. They can have edematous in extremities. So make sure to check their pulse, use Doppler if needed. They can have compartment syndrome. So in that case, do a surgical consult. Once the patient has been stabilized, then there should be a decision of if the patient needs antivenom or not. Remember, as a thumb rule, more distal the bite is on the extremity, there is going to be less toxicity of the venom. So now, who is a candidate for antivenom? Normally, it is people who have moderate or severe envenomation. These are the candidates. Now, this antivenom is the most common one that is used is FAB antivenom, which is basically an ovine or sheep derived antivenom. For exotic snakes and coral snakes, there's also a horse derived, but again, the most common is this FAB antivenom. In rodents, the initial dosing of the FAB antivenom is actually described by the severity of the envenomation. So if it is moderate, they recommend 4 to 6 vials as an initial dosing. If it is severe, then 8 to 12 vials, and if it is very severe, then they recommend 12 to 18 vials. So this is the algorithm that has been mentioned in Rosen's. So let's take it one by one. If the patient comes with minimal envenomation, so we need to observe. If we notice that the patient is quite stable, there's no progression, then no antivenom is needed. But if the person progresses, then we are going to move on to the moderate pathway. So in the moderate pathway, if a patient has moderate envenomation, then 4 units of the antivenom should be given over 60 minutes, and then we observe the patient. Again, if the patient is stable, there is no progression of the disease, then no further antivenom is needed. But if it is not brought under control, then we are going to follow the severe pathway. In severe pathway, again, we are going to give 4 units over 60 minutes. Then we are going to check, has the patient been brought under control? If the control has been achieved, then we start the patient on maintenance, which is 2 vials every 6 hours, repeated 3 times. If it has not been brought under control, then we are going to give another 4 to 6 vials, and then we are going to check if it has been brought under control. If it has been brought under control, then we will move on to the maintenance. If it is not being brought under control, then we are going to repeat giving antivenom till the patient is basically stabilized and the situation is under control. Some points to consider. Anaphylaxis to antivenom can occur, so it is best if we can have the appropriate agents prior, like oxygen, airway support, epinephrine, corticosteroids. Some practices, they actually advocate for giving 0.3 milligrams of 1:1000 epinephrine to prevent allergy if there is no contraindication to the patient. Pregnancy in itself is not a contraindication to antivenom. Do not administer at the site of the bite, it is no longer recommended. Kids often require double doses compared to adults. Remember that wound care applies to these bites. So clean the area, examine for any foreign bodies. Tetanus immunization should be up to date for the patient. Broad spectrum antibiotics can be helpful. Now, in some patients, giving antivenom can actually cause them to develop serum sickness. This can be managed by giving diphenhydramine, cimetidine, and corticosteroids. Remember, serum sickness is the only indication for giving corticosteroids in a snake bite. So in a normal patient with no envenomation and no other signs and symptoms is otherwise stable, we can observe the patient for 6 to 8 hours and then we can discharge. If there is some local pain and minimal edema, then the patient can be discharged, can be observed for 12 hours. Coral snakes are an indication for ICU admission and they need monitoring for 24 hours. And this concludes our topic of snakes. In the next video, we'll discuss the arthropods.